A very good morning to one and all. In continuation with the last presentation on residual resorption, there is an added presentation with it regarding the impression techniques in complete nature for the resorb business. So the residual ridge is a term used to describe the shape of the ridge, angular ridge, after healing of bone and soft tissue following the procedure of extraction. Once the teeth get extracted, resorption of the ridge starts taking place. Resorption is the loss of tissue substance by physiologic or the pathologic process. According to the glossary of prosthonotic terms, residual ridge resorption is defined as the term used for the diminishing quantity as well as the quality of the residual ridge after the teeth being extracted. The residual ridge resorption is considered as a multifactorial biomechanical disease that results from a combination of anatomic, metabolic, and mechanical determinants. There is a variation of resorption in different patients at different sites, at different stages of their age. It is mainly because the reason behind this disease is a combination of factors and cofactors in numerous ways. Residual ridge resorption is a chronic, progressive, and irreversible cumulative disease. That is the combination of all these. So, as prosthodontists, our main concern is to incorporate proper impression techniques and measures to minimize the resorption of the ridge and the residual resorption in the planning of our treatment. In 1971, Atwood described residual resorption as a major oral disease entity characterized by loss of oral bone after the procedure of extraction of teeth. Residual ridge resorption is a term that is used to describe the changes which affects the alveolar ridge following the process of extraction, which continue even after healing of the extraction socket. The process of ridge resorption goes on even after the healing of the extraction socket. Compared to the maxilla, the mandibular ridge resorption shows a more severe resorption. The reason behind is the rate of resorption is comparatively very fast in mandible than in maxilla. In patient with severe residual ridge loss, implant supported dentures cannot be considered as a treatment modality. The implant treatments are still too expensive for the majority of elderly people. So the main mantra we should follow was said by M.M. Devan is that the perpetual preservation of what remains is far more important than the meticulous replacement of what is missing. So many authors describe different impression techniques regarding the atrophied or the residual ridges. So this presentation combines all the different impression techniques described in the past for the atrophied or residual ridge resorption cases. So what are the different impression techniques? Firstly, the conventional technique, then the dynamic impression technique, dynamic impression, second technique, dynamic impression, third technique, Klein's technique, Admix technique, all green technique, functional technique, cocktail impression technique, given a technique given by Chandrasekhar Nair, elastomeric technique, fluid wax, modified fluid wax impression technique, neutral zone technique, Klein's technique, Arthur S. Freezy given a technique, secondary impression. So, first of all, the conventional technique. The impression which is made by using the conventional method, that is the zinc oxide eugenol wash impression, which is followed usually done after the bottom molding or the peripheral molding is being done by the help of green stick compound in the open mouth technique, open mouth position. Uh, the figure showing the zinc oxide ethanol final impression, which is usually followed by the peripheral border molding by the help of green stick or the tracing compound. Secondly, the dynamic impression technique. Fabrication of special tray is being done. There is a range of self-curing resin. That is a special tray of self-curing resin is built up in the premolar region on each side of the to support the thermoplastic material. While the thermoplastic material is soft, the tray is placed in the position on the lower jaw in the mouth, and the patient is asked to close the mouth slowly. The upper residual ridge will form an impression in the soft thermoplastic material and a height corresponding to the rest of the mandible. Then the tray is removed from the mouth and cooled. Lingual mandibular rests should be concave to provide a space for the tongue. Sufficient amount of an irreversible hydrocolloid is mixed with 50% extra water and material are placed directly in the mouth to cover all the tissues. The tray is pressed through alginate by digital force until the stops are firmly seated on the residual ridges. Then the patient is asked to close his mouth slowly until the mandibular rests have been obtained from contact with the maxilla. The patient should swallow 3 to 4 times at 10 seconds at an interval of 10 seconds while the final impression material is still in a moldable condition. The patient is asked to do a swallowing movement 3 to 4 times at an interval of 10 seconds while the final impression is still in a molding stage. The action of the muscles that functions in deglutition is accentuated because the mandibular rest prevents the mandible from reaching the vertical relation of occlusion and forces it to remain in the rest position. This procedure develops a registration of the denture space, while ordinarily results in proper extension of the lingual phalanges of the finished denture. A forceful protrusion of the lip brings the mentalis and orbicularis oris muscle into action and is responsible for forming the labial part of the impression. So the dynamic impression technique, second technique. In this method, an old denture can be used for impression making while opposing natural or artificial teeth are present. The old denture can be used as a template for making an impression. Often the vertical dimension of occlusion is decreased, hence the steps are placed at re-established height. Why the patient needs a new denture? Because the vertical dimension of at occlusion has already decreased. Why? That is why the patient needs a new denture. So using the old denture as a template, we can make this impression, secondary impression, and we have to re-establish the vertical height while doing so. The mandibular rests are built up until including the interocclusal space distances. Dynamic impression, third technique. The denture is processed conventionally, then a correcting dynamic impression is made in the denture base to reshape and complete the final design, and the denture is relined. The whole of the intaglio surface of the denture is replaced by a new denture based material that is known as the relining of dentures. Another technique is Klein's technique. In this, stop trays will cause some tissue distortion as it may not exactly fit over the tissues. So, Klein's proposed a method without using a stop tray. A moldable material like putty silicone was placed over the residual ridge and borders molded with speech exercises. the material was reinforced by an internal metallic core. A functional preliminary impression is made using a low viscosity material which is placed on the impression surfaces of the customized print. Another technique is admix technique, which is proposed by McCord and Tyson. In this impression technique, impression compound and the tracing compound, that is the green stick, are taken in the ratio of 3:7 by weight, and they are placed in bowl, hot water bowl, which is at around 60 degrees centigrade and kneaded homogeneously until we get a homogeneous mass, which provides a working time of almost 90 seconds. This homogeneous mass is loaded to the tray after wax spacer is removed, and the patient is asked to do a various turn movements to record the borders. This is the impression which we obtain after the procedure of impression by admix technique. Another technique which is known as all green. In this technique, the mandibular secondary impression is made using tracing of the green stick compound. The green stick compound is kneaded to a homogeneous mass and was loaded on the special tray, and border movements were done. The final impression is usually made by the zinc oxide eugenol material. This is all green impression. Then another technique is the functional technique. The technique was proposed by Winkler, and it is a closed mouth functional impression technique. So the movements are done by the patient while the mouth is closed. This is how the impression is being recorded. So in this technique, a denture base and occlusal rims are fabricated on the primary cast. Denture base and the occlusal rims are fabricated on the primary cast, and a tentative jaw relation is being done. Tissue conditioner material is applied on the tissue surface of the mandibular denture base. We ask the patient to do various functional movements such as puffing, blowing, whistling, and smiling. These are the functional movements which we ask the patient to do. This is the tissue conditioner, and the maxillary is the occlusal rim. Re-application of tissue conditioner material is done at the interval of 8 to 10 minutes. The mandibular area is applied by tissue conditioner in a step of three steps at an interval of 8 to 10 minutes. The final impression is made with light body, that is the addition silicone material, in closed mouth technique. Another impression technique, very famous technique for resorb bridges, that is the cocktail impression technique. In this technique, a customized tray is fabricated according to the dynamic impression technique using an autopolymerizing acrylic resin. A tray with cylindrical mandibular rest in the posterior region and 1 mm spacer is made at an increased vertical height. These are the specifications we use to fabricate in the special tray. The patient is then advised to close his mouth so the mandibular rest fit against the maxillary alveolar ridge, like in the case of dynamic impression. This is how the patient is asked to close the mouth. The vertical rest helps to stabilize the tray in position. The lingual surface of the mandibular rest are concave. McCord and Tyson technique for flat mandibular ridges is followed for a definitive impression, and functional movements are usually done till the impression material gets hard. Another technique given by Chandrasekhar Nair. He used an irreversible hydrocolloid material for the recording the mandibular primary impression. A tray devoid of spacer is made over the primary cast using the autopolymerizing acrylic resin. The custom tray is adjusted to a 2 mm short of the functional depth. The crest of the ridge is marked using an indelible pencil and transferred on the tray by placing the tray over the ridge. Then a window is cut in the tray using a burr which is outlined the area corresponding to the crest of the ridge. The tray is then seated on the cast and a softened modeling wax is placed into the window, thereby replacing the eliminated acrylic resin and shaped to form a handle. Putty consistency elastomers with tray adhesives on the borders and the entire surface of the custom tray are placed on the tray. The tray is seated on the ridge with a window corresponding to the crest of the ridge, and the labial and a lingual borders are molded. The handle with modeling wax. The handle is made with the modeling wax. The area of overextension indicated by exposure of the tray borders and corrected by removing the putty in the corresponding area by trimming the tray. The second application of putty is made over the first and the borders are molded again. This process is done again while the second application of the putty is done, the border is molded again. The borders of the impression are carefully re-examined for any other under or over extensions and corrected accordingly. The borders are again re-examined and we should do a thorough examination while regarding the under extension or the over extension of the impression. The borders of the impression are trimmed by 5.5 mm using a sintered diamond burr. The wax handle is then removed and putty material over the window is cut. Then a light body elastomeric impression is loaded into the tray, which is then seated on the ridge. Additional light body material is then expressed onto the windows. Lingual and facial borders are molded, ensuring the tray remains steady until the impression material takes a firm set. Another technique is an elastomeric impression technique. In this kind of techniques, the mandibular secondary impression was made using an elastomeric impression material, that is a light body impression material. Tray adhesive is usually applied on the borders and external and internal surface of the acrylic custom tray to facilitate the retention of the silicone border molding material. An additional silicone putty material with extended working time is loaded along the borders of the special tray. The special tray is placed in the mouth and the borders are molded. The patient is asked to move the tongue according to the standards of the impression procedures. This is how the elastomeric impression looks. The tray is then removed from the mouth and the impression is examined thoroughly. The light body addition of silicone impression material is loaded in the impression and reinserted in the mouth. The patient is then instructed to repeat the tongue movements which were done earlier, but the movements are somewhat vigorous. While the light body impression material is border molded along the buccal and the labial flanges area, after the material sets, the impression is removed from the mouth and examined for any kind of discrepancy. Another impression technique is modified fluid wax impression technique. The preliminary impression is recorded with an irreversible hydrocolloid, that is an alginate, a custom impression material. A custom impression tray is fabricated on the preliminary cast. Softened modeling plastic impression compound is placed on the integral surface of the tray corresponding to the region of the mandibular central incisors and both the mandibular first molar to serve as spacer for the wax. A segmental border molding procedure is done with a compound. Spacer are removed with the scalpel blade once the border molding is complete. The tray is trimmed over the crest of the residual ridge to form window opening above the displaceable ridge using a 8-number round bar. Mouth temperature impression wax is melted and applied on the borders of the tray. We should ensure that the wax temperature is less than the working temperature of the modeling plastic impression compound to prevent any kind of distortion. Then we place the impression tray immediately over the edentulous ridge and leave it in the mouth for approximately 5 minutes. We allow adequate time for the mouth temperature impression waxes to flow and escape to the periphery of the impression as well as to solidify. Then we apply the impression wax onto the entire surface of the tray by adding the impression wax onto the slopes of the ridge rather than the crest in increments until a glossy surface is visible. We trim any kind of excess impression wax on the periphery or anything over the window opening with a scalpel blade. Then we apply a tray adhesive on the tray in the surrounding area of the window opening and then we allow it to dry. Then we place the impression tray on the residual ridge and inject vinyl polysiloxane impression material over the window opening, preventing distortion of the soft tissue by placing the impression material in the most passive manner possible. Then we remove and box the impression using a mix of plaster and PMS. We avoid using any conventional boxing procedure that requires boxing wax as it may distort the impression wax. So we should prevent and take thorough precaution regarding the distortion of any kind of distortion of the impression waxes. Another technique of recording the residual ridges is a neutral zone technique. In this kind of technique, the primary impression is made using compound or impression plaster. Upper wax rim and lower special tray, which is a plate of acrylic self-cure resin, is adapted over the lower ridge with screws or pins projecting upwards towards the upper arch, which helps in the retention of the impression material. The upper wax rim is adjusted as in normal registration form of complete denture. The lower special tray is then placed in the mouth. 2 occlusal pillars are built. Then 2 occlusal pillars are then built up in self-cure acrylic resins on the opposite side of the lower arch. These pillars are molded and adjusted to the height of the occlusal height to the given usual 3 mm to give a usual 3 mm previous space. A thick mix of viscogel is then placed around the rest of the lower special tray, distally and medially to the occlusal pillars. The patient is then asked to talk, swallow, and other movements. That is the functional movements. We ask the patient to make some functional movements so as to record the muscle movement of the patient. After 5 to 10 minutes, the impression material. After 5 to 10 minutes, the set impression material is removed from the mouth and thoroughly examined. The patient's musculature will mold the viscogel material in position of balance. That is a zone where the tongue movements and the lip lip muscle forces are equal to each other. So the viscogel usually records the patient's movement when the both the muscles, that is the tongue movement and tongue muscles and the lip muscles are in balance of each other. Indices are then constructed with plaster and wax is filled into it. The teeth are arranged in according to the wax rim, which is fabricated according to the new indices. A more comfortable and more stable and retentive dentures will not interfere with the function of lip, cheeks, and tongue. So, this technique, that is the neutral zone technique, usually records the zone which is in equilibrium with the forces of all these muscles, that is the lip muscle, the cheek muscle, and the tongue. Another technique is a flange technique, which is given by Frank Lott and Bernard Levin. They suggested that anatomic and physiologic approach to increase retention, function, comfort, and appearance of denture. So they introduced this technique in 1966, which involves making of impression of soft tissues of adjacent or soft tissues of mouth adjacent to the buccal, the lingual, the labial, and the palatal surface, and incorporating the incorporating the resulting extension or the flanges of the dentures. Flange wax was rolled on the retromolar pad area to the sublingual region large enough to restore the diameter of estimated resorption, and patient is asked to forcefully perform functions of swallowing and other movements to give a border extension which covers the maximum surface area. Another technique which is given by Arthur Freezy, the objective is to make an impression which records the surface of the tissue without excessive displacement in the positions they occupy when they are in function. The main objective of this kind of impression is to record the surfaces of the tissue without excessive displacement in the position when they are in function. An oversized soft metal impression tray is selected and trimmed without any attachments of border tissue. A low heat modeling plastic is used, and patient is instructed to run the tongue along his lip and suck his cheeks, pull in his lips, and open and close his mouth. Usually, the functional movements are being asked for the patient to do. Another technique is a secondary impression technique. Acrylic resin tray is made and carefully checked, that is, it does not displace any peripheral tissue. The wax stops are built on the tray. The wax stops are built until the vertical dimension at the contact is increased about 3 to 4 millimeters beyond the normal vertical dimension. The self-curing acrylic resin reline material is prepared and placed in the tray. The patient is then instructed to bite onto the wax stops and directed to the movements like swallow, tuck in the cheeks and lips, and extend his tongue through the spaces between the stops until he can touch his lips and cheeks. The final impression is made using the zinc oxide eugenol impression material. This is how the secondary impression looks like. So to conclude, the preservation of supporting tissue is a sacred trust that cannot be ignored. The application of basic concepts and advances made in the basic sciences will help to keep the trust in the hands of the dental professionals. As prosthodontists, we need to perform the most meticulous and intelligent prosthodontic care of the patient within our capabilities, and then it would not seem a nebulous hope that someday there will be a control over residual resorption. The utilization of different impression methods, as mentioned above, can be chosen in different cases according to the clinical experience and knowledge.